So I'm sure everyone's aware that MSC has a history of innovation, and I can think of occasions every week where I'm thankful to have an MSC product for a complex cataract surgery or to get me out of a situation that's not desirable. In the glaucoma space, the devices there have really taken off as well. So we're getting all sorts of products coming on the market that have different designs, and it's hard to know which one stands out or which one might be better than the other one. MST, of course, has thrown their hat in the ring and have the Trabex blade and the Trabex Pro there on the right, and that has an added IA feature that has some unique upsides. But the blade is unique in that it's laser cut, it's serrated, and it's this trapezoidal shape. So what's the benefit of this trapezoidal design? And this is what initially drew me to the device. But it's 66 microns at the tip, and it gets wider as you go up the blade to 330 microns. And it has a trapezoidal shape, so you can custom cut that tissue. Patients are gonna have variable phlegm canal anatomy and variable trabecular tissue, and having this trapezoidal shape can kind of fit to that anatomy. That you're going to see variability patient to patient, but what's really interesting, I think, is that you see variability within a patient. So this is a cast of the phlegm canal and the trabecular tissue, and it just shows how much within one system a patient's going to have some variability. You'll also see variability between primary open angle versus closed angle disease. And then, like we mentioned earlier, patient to patient, it's going to vary as well. This is one of my early surgical videos, and I think it does a nice job of illustrating the nice wide goniotomy you get with the Trabex blade. You see, I'm just engaging TM tissue here and moving along. As you can actually see pigmented TM and non-pigmented TM. So you actually get that like live view of histology in action, but you can see the non-pigmented and the pigmented TM. So that's just proof that you're really taking out the full trabecular tissue. And a lot of blades are like the flat foot, you kind of have to get flat against the posterior wall of canal and move along. The Trabex blade is more of like a stiletto. So the angle of approach to the TM is a little different. So keeping that in mind as you move along to do your goniotomy is important. It does have a sharper tip. And so I think there's obvious advantages to a sharper blade, but you have to be aware that you can snag the back wall of Schlemm's canal as you go along. So you just have to make sure your arc and your approach is proper. It's less like a pencil and more like a highlighter. So it's just got a larger barrel or larger caliber handle. There's so many MIGs out there. There's viscodilation, there's stenting, and like I mentioned earlier, things are taking off. There's options. So why do goniotomy? I think it's very apparent there's a long-standing history and a lot of research with goniotomy. We know it can provide access to multiple collector channels. In a lot of ways, it's nice to be device-free, as you might have patients that prefer to be device-free. And the surgical technique is very simple, like I mentioned already. You can use it in a lot of different glaucoma types and diseases. I think of it sort of like the chameleon of MIGS. You can use it in open angles. Closed angle, it's great because you take out the cataract and then you address that diseased trabecular tissue that has had intermittent contact with the iris. Secondary open angles, where the disease is right there at the TM, it's a nice option for that. And then with standalone or in combination, and prior glaucoma surgery. So as you can see, the list is long and there's a lot of different ways to use it. We don't have data that for every single new device that comes out, right? And so I really wanted to see what my Trabex cases were looking like. So at a small team, and we went back and looked at 6 months outcomes for combined phaco Trabex goniotomy. I wanted to look at the safety and the efficacy, of course, and the ability of this procedure to reduce medications and to reduce IOP. It was retrospective, so I went back and looked at basically from the moment I switched to the Trabex blade to the moment I left Cincinnati, I was doing this study. And so I included almost anybody. I wanted it to be like a real world study to really get a capture at what it's like. They had to be adults and they had to have glaucoma, and they could have any glaucoma and any severity. I did exclude them if they had had recent SLT, prior incisional surgery, or if something complicated happened during their cataract, or if their cataract surgery had another procedure like ECP or something else that might affect the pressure outcome. And so we're looking at 6 months surgical success, and that's defined by a pressure reduction of at least 20% and or reduction of one medication. Because a lot of these patients that were going in for their surgery don't necessarily need a pressure reduction. I was just trying to reduce their medication. So I think just outcome does a nice way of capturing that. For outcomes, mean pressure reduced from 18 to 13. and meds went from 2.46 to 1.45. Our surgical success was actually 92%. And so I wanted to kind of break that down and look at how people were meeting the success criteria. So what I did, and I'm very particular about my charts, I always have a target pressure range for my patients documented. And also I kind of carry that forward according to their progress. So if the patient was controlled, like in target range, and no medication escalation was occurring, they were considered controlled prior to surgery. Same thing at 6 months. If they weren't having any medication escalation and they were in target range, they were considered controlled. Over the follow-up period, mean IOP was statistically lower at all time points except for week did that, and med reduction was significant at every time point. And I think phaco combined with a Trabex goniotomy is safe and effective at lowering pressure. Literature results are at minimum comparable. And there was interestingly, no difference in results based on disease severity or open versus closed or prior trabeculoplasty. And there was a complete lack of significant hyphema. So my theory on this is perhaps could be blade design. It's sharper, less shearing, more cutting than shearing. Or it could be my practice pattern that I stop glaucoma meds right after surgery. And so there's less pressure dipping and less blood reflux. And that would go along with my higher pressure spikes at 1 week. We need prospective longer term follow-up of these patients. And of course, Dream State is like a head-to-head study. So that's all I have.
If you are someone who's new to goniotomy, what is a great starting point as a patient who's a candidate for Trabex or a goniotomy procedure?
I think I love the idea of starting with a combined case because it's not like you're taking the patient for just that first procedure that you're learning. And I think a wide open angle with great pigment that you can see in the clinic is very helpful. Prior to that, just getting used to gonioscopy in the OR before you're actually doing any MIGS can be really helpful. That way there's no pressure to perform the actual surgery. You're just trying to get comfortable with that view.
For those of the audience members who are not familiar with Trabex Pro, can you tell us a little bit about the device and your experience with it?
It cuts and looks just like the Trabex, but it does have irrigation and aspiration of it. But basically, there's tubing that connects right up to the phaco machine. Your rep can help you set up the settings, but it just gives you instantly like irrigation. You don't even have to open up viscoelastic necessarily unless you really want to, but you get irrigation, a perfect view the whole time because you're not burping out viscoelastic or indenting the cornea. And then as you go along and make your goniotomy strip, you can aspirate any pigment or blood or anything that gets in your way.
You, Dr. Provencher, you showed some great video today with a huge strip of TM that was very visible. It was really cool to see the pigmented versus non-pigmented TM. What technique advice can you give our audience to get a nice, beautiful strip of TM removed like that?
I think the best thing is to be confident of as you engage the tissue. If you come in and out and are going along being hesitant or too light with your touch, you can cut that strip into multiple pieces. But really getting that stiletto tip into that Tischlem's canal and moving along in a smooth way, keeping in mind that this is a curved surface, is really important. You'll get a big single strip.
Well, Dr. Provencher, thank you so much for sharing your expertise with us today. Really exciting data. And let's give a round of applause for Dr. Lori Provencher, ladies and gentlemen.